to our speakers, Carla Brock-Wilbur and Louise Bride. Carla Brock-Wilbur, an accomplished nurse administrator with a background in critical care, education, and emergency services, joined Strumwater in 2014. Before Strumwater, Carla was Director of Enterprise Excellence. In this capacity, she led, facilitated, and supported the Lean Transformation Initiative across the continuum of care and health systems, and was responsible for the development, implementation, and ongoing assessment of comprehensive performance improvement and lean redesign initiatives within the healthcare facility. Carla is also a seasoned clinician and worked directly with patients in the facility's outpatient surgical department as both unit coordinator and as an endoscopy registered nurse. Louise Bride joined Strumwater in 2013 and has more than 30 years of experience in healthcare management and clinical operations. She has a proven record of accomplishments in developing and executing initiatives to enhance access and improve quality and cost effectiveness of healthcare delivery in both the public and private sectors. At Strumwater, she focuses on population health, strategic planning and operational improvement, and models of care, including patient-centered medical home initiatives. Before joining Strumwater, Bride formed a healthcare consulting firm specializing in care integration models of care delivery, provider relation network development, and a star rating, evaluation, and improvement initiative. Previously, Bride served as Senior Clinical Director for United Health Group, Ovation, in Atlanta, Georgia, where she held the national clinical lead role for Ovation's Medicare community programs. She is a member of the American College of Healthcare Executives and is an NCQA Patient-Centered Medical Home Certified Content Expert. Now I will turn it over to Carla and Louise.
Thanks, Kim. I'm just going to get us started here with a little bit about, I do want to say a little bit about Strumwater. We are a firm that is now 31 years old. We have in the neighborhood now of about 35 consultants. We have a rural practice specifically. We also work with other community and network systems in affiliations and partnerships, capital planning and access, physician-hospital alignment, population health and employer health strategies, a revenue cycle management division, a strategic master facility planning area, and strategic planning and accelerated operational improvements. Today our learning objectives will be to understand the financial context of post-acute care delivery, including comparisons related to costs, review the recent history of bundled payments, identify bundled payment success factors, and explore the CJR model and its implications for post-acute care. First, we'll start with the post-acute care lexicon. IRF acronym is for Inpatient Rehabilitation Facilities, SNF for Skilled Nursing Facilities, what we usually refer to as LTAC, Long-Term Acute Care and Long-Term Acute Care Hospital, and HHA Home Health Agencies. And the relative cost associated with each of those is shown. Inpatient rehabilitation facilities being the most costly of the post-acute cares. With the passage of the ACA, our Affordable Care Act, in 2010, there's been a heightened focus on the Institute of Healthcare Improvement's triple aim of improving our patient experience of care, population health, and reducing per capita costs in health care. However, post-acute care has not historically been on the radar until 2013, when an Institute of Medicine report identified the post-acute care as a source of 73% of variation in healthcare spending. literature consistently shows post-acute care as the primary driver of variation in Medicare spending. It's estimated that as many as 43% of Medicare fee-for-service beneficiaries are discharged to one of the Medicare-recognized post-acute settings: skilled nursing facilities, long-term care facilities, and inpatient rehab facilities, as well as home health. Between 2001 and 2012, program payments to post-acute care providers doubled to $59 billion, and that was to over 29,000 post-acute care providers. The next slide shows Medicare spending on post-acute care by sector. There is a variation in some of the dollar amounts and billions from the April 2015 information as opposed to the June 2015, but it's just a small variation. But as you can definitely see, the total of our Medicare spending has increased from 2001 at $29 billion to $59 billion in 2013. Average episode spending shows that there are significant differences in costs related to the initial post-acute care setting following hospitalization. The dark blue that you see in this bar graph is what we refer to as the anchor admission, and that is when the patient was hospitalized. It's important to note that as hospitals and health plans move into a bundled payment arrangement, we can expect to see a decrease in the inpatient rehab and skilled nursing facility utilization due to the cost and a shift to a less costly setting of care. As you can see, the second from the top is self-care, which is the least expensive, and right below that, the inpatient rehab being the most expensive. Typically, inpatient rehab facilities are hospital-based units, so it makes sense that this is the most expensive episode of care. In addition, patients often transfer from the IRF to a SNF or home health instead of directly to home with self-care, which increases the cost. I'll turn it over to Louise.
Okay, great. Thank you so much. Can everyone hear me all right?
I can.
Okay, great. Well, please let me know if at any time I hear. So yes, my name is Louise Bride. Again, I'm a colleague of Carla's at Strumwater, and we are pleased to have this opportunity to talk with you this afternoon. Before I dive into the discussion about bundled payments, I did want to mention some information that's an update to some of our conversation last week when Carla talked a good bit about transitions of care, and in particular readmissions, which are costly from a penalty standpoint for the hospitals and become particularly important in a bundled payment environment, which we will talk about in just a moment. And we were talking about it in the context in particular of hospitals' relationships with the local post-acute care facilities at which their patients are, to which their patients are maybe discharged. And so I wanted to share with you an update that has just recently come out. CMS has recently added 2 new quality measures for short-stay residents in nursing homes. They have added these 2 quality metrics to Nursing Home Compare, which is the national website. And beginning this month, in July of 2016, CMS is going to incorporate these measures into the 5-star quality rating program. And it's very relevant for all that we talked about last week, because those 2 new metrics, one involves rehospitalization after a nursing home admission, and the other metric is around, again, for short stay residents in these nursing facilities, an outpatient emergency, a metric related to outpatient emergency department visits. And the information goes on to say, as we discussed last week, that hospitalizations and hospital readmits have become a top priority for CMS, both because of the potentially negative consequences for the patient, both from a physical potential for complications, and then also the emotional impact, particularly for frail elderly individuals. And then again, of course, the tremendous cost impact for Medicare. And so it really just further underscored much of what we spoke about last week, and is a significant factor in why CMS has moved now to look at other payment reimbursement methodologies, including bundled payments. So when we talk about a bundled payment, what does that mean? What is the definition? And essentially, the common standard definition is that in a bundled payment arrangement or a bundled payment model, the entity that's involved receives a single payment from a payer. In this case, our examples will be CMS as the payer, and that single payment then covers all the related services that have been identified for a given condition or episode of care. And that the bar chart that Carla just walked you through was really showing total costs for an episode of care based on or really looking at it specifically from the standpoint of the post-acute care period. So that's in a nutshell what a bundled payment model is all about, is that an entity, again, receives a single payment, and then depending on the bundled payment model, depending on the focus of that particular program or initiative, really then determines what is the constellation of what are the services that then get gathered together to create that bundle. When designing a bundle, if one of the core goals, which it is for CMS as an example, when it's to improve value, then the recommendation is that that bundled payment should include clear quality metrics focused on desired clinical outcomes for the particular condition that's being addressed, and that providers have to achieve in order to maximize their payments under that bundled payment arrangement. And we'll talk a little bit more about that with a specific example a bit later on in the presentation. So that's in a nutshell, as I say, what the definition is. If we move on, then this slide is really talking about kind of comparing the traditional episodic, fragmented, if you will, fee-for-service reimbursement environment in which everyone has operated for a very long time, where in this case, Medicare, the payer is making separate payments to each of the providers involved in delivering the individual services to the beneficiary, typically for a single illness or a single course of treatment. And as we all have known and experienced, that can often result in pretty episodic, fragmented care and a lack of coordination across the care continuum and across the array of providers involved in delivering all the various services to that individual. And as we've all been hearing increasingly, it's really in that environment paying for volume, not for value. So CMS has been very intentional in moving to testing out this bundled payment approach to really change and better align the incentives from a reimbursement standpoint for all the key parties involved in delivering services for that episode of care or for that particular condition, whatever condition has been identified for purposes of the bundle. One of the first, I guess actually the first bundled payment initiative that CMS launched was the Bundled Payments for Care Improvement Initiative, and that was launched actually in 2013 and was voluntary, so a voluntary participation basis. and it was created the capability to have that sort of a reimbursement methodology or model was really created in the Affordable Care Act and was intentional, again, to test innovation in both payment and service delivery models with the goals of, as you see, reducing costs for the various federal programs. In this case, commercial payers have also embraced the bundled payment arrangement for very similar reasons. And again, also to preserve or actually enhance the quality of care and definitely to improve the continuity of care across that delivery system, across that continuum of care. One of the updates that I can share is, and it's just been announced, CMS has very recently announced that they are extending this initiative, which, as I say, was started in 2013. And they just have announced that participants will be given the opportunity to extend their participation through September 2018. So clearly CMS is encouraged by early results and has made that decision to extend this particular model. The model allows for 4 different options. Models 1 through 4, as you see, and 2 of those include post-acute care as a component of that bundled arrangement. So typically a bundled arrangement will include the hospital, it will include the directly relevant physician services, it may include certain ancillary services, all of which are defined for that given bundled arrangement. And then in this case, and our primary focus for today is around those bundles that include post-acute care. And as you see, that's indicated on this chart, that 2 out of the 4 are explicitly including post-acute care. That would be Model 2 and Model 3. So if an entity chooses to participate in one of those models, then post-acute care services are scooped up and included in that bundled payment arrangement, and so all of the costs associated with those particular services are all gathered together for then that episode of care. And as you can see, in this example, in the Bundled Payment for Care Improvement Initiative, inpatient hospital, physician services, all the related post-acute care services, and related readmission costs are included. Further really underscoring why attention around transitions of care and really a concerted effort across all of the participating parties to reduce readmits becomes so important from the standpoint of managing total costs in that bundle. Again, this particular initiative is voluntary. One of the goals from CMS was really to create opportunities for hospitals and these various provider groups and entities, post-acute care entities, was to really gain experience partnering and working together to manage care in this sort of new reimbursement environment. This is a little bit more detail about the 2 different models. I won't go into all of this. In both cases, there has to be a trigger event. Model 2, the episode starts with that initial hospital stay for one of the included MSDRGs. And then you see it goes on to discuss the various options that the participants may select. And that would be to include a 30, a 60, or a 90-day time period following hospital discharge. So what that would mean then is all post-acute care services provided in whichever was the selected time period would become a part of the bundled arrangement. Model 3 is definitely a bit of a different cut of a different approach, and that includes only the post-acute period, and so the episode starts upon hospital discharge and then can run for 30, 60, or 90 days, depending on what the participants would select. becomes really important then for all of the parties participating in a bundled payment arrangement to do a very thorough and accurate job of identifying all of the typical components of cost so that they then can come up with a really realistic idea of what a typical episode of care for that particular condition will likely cost, to then be able to look at how that compares to the price that the payer is offering, and then to determine what their risk is for their cost to exceed the amount that the payer is willing to pay for that episode of care. So unlike the traditional fee-for-service reimbursement environments, the parties participating in a bundled payment arrangement enter into some financial risk. If they underestimate what the total cost will be for that episode, then the entity will actually lose money, or in some instances, depending on how the arrangement is structured, they might actually have to pay something back to the payer if they have exceeded the threshold of the expected cost. So critical that the parties are really careful, as I say, and that they're closely looking at their historical cost data to figure out whether this is a viable arrangement for them or not. And so this next slide is talking about some of the critical success factors in order for an organization and entity to really be successful in a bundled payment arrangement. And first and foremost would be, as I've been discussing, to really do an accurate job of identifying and defining those services and understanding their costs and the expected volume or utilization. And then one of the other aspects of a bundled payment environment is that there's opportunity in many cases for the participants, and particularly driven by the hospital, if it's a model that includes hospital services, would be to really take this opportunity to look at care redesign and to identify is there unnecessary care being delivered? Are there opportunities to reduce complication rates? So infection, if it's a surgical intervention, are there opportunities to improve surgical outcomes, to improve the members' or the patient's functional status? So that orthopedic surgery would be a great example of that, so that they're really looking very closely at the cost and the results of the services that are delivered to find ways to be as efficient as possible and to really standardize the care delivery, to base the delivery on evidence-based care so that there is then reduced variation and reduced opportunity for error or for poor outcomes, all of which would potentially drive up the cost and result in a financially unsuccessful arrangement for the participants. So that's an overview of really the general concepts of a bundled payment arrangement, and also some discussion about CMS's first foray into this environment through that voluntary bundled payment for care improvement initiative. Let me just pause with that and see if there are any questions before I move on to the next example. Any questions about what a bundle is all about, or how this works?
Louise, there was a question on slide number 6.
Okay.
A question, does this imply that there is less readmission costs when patient discharged to self-care?
I'm sorry, so ask me that question again. I'm sorry.
On slide 6, does this imply that there is less readmission costs when patient discharged to self-care?
Oh, you're looking, okay, let me get back to that slide, yeah. What it's saying is that if you think in terms of, again, this is really looking at an episode of spending following hospital discharge, and it's showing all the different possible settings of post-acute care. And what it's saying is that in many instances, an individual will start out in one post-acute care setting, but over the course of their recovery or their recovery from surgery or the illness, whatever the particular situation is, that they often will use more than one post-acute care setting. So in the top bar, that top line, that's showing that the first setting to which the patient goes is to a skilled facility. So they've been in the hospital for some event, and they then are discharged to a skilled nursing facility. And likewise, line 2 is they're discharged to home or to their residence for self-care. And what it's showing is for individuals who go home as their first setting following hospital discharge, on average, their total cost of care for the post-acute care period is less than for any of the other settings. Inpatient rehab would be the most expensive, as you can see by that third bar, followed by skilled facility. So that really your two institutional settings, and as Carla said, that makes sense because you have all of the facility costs as well as the professional services of the providers. In the home, in the discharge to home, then there it's showing the lowest cost of the total episode, and it also is showing a pretty small readmission component of your total line of cost. So that's just showing how your costs break down in this, and the focus here was really showing the differences in total cost based on the first setting of post-acute care. It's showing, actually, in this example, the readmit component, which would be the red bar, is actually the smallest for individuals discharged to home health. You would find in any given plan, health plan or a hospital system, those combinations will vary. But what it really is stressing is that the first setting of care is a real important determinant of the total cost for that episode, and that the least expensive option would be self-care. So as hospitals and health systems move increasingly into alternative payment arrangements like a bundled payment arrangement that we're talking about today, they are increasingly looking at what happens in that post-acute care period. And the expectations are that over time there will be a reduction in the number of folks going to the institutional settings, and that the hospital systems, the health plans, the payers will make every effort to discharge their patients, their members, to lower cost setting of care for the first setting, which would be either discharge to home for self-care or home health, home with home health care services as supportive services. The expectations are that there will be intense pressure. It's already happening, and that will continue as these bundled payment arrangements grow. There will be intense pressure to avoid admitting somebody to the most expensive settings, which are the inpatient rehab unit setting and the skilled nursing facility setting. So that's really the major focus of this particular slide, is really trying to get at that and to show the differences in total cost that are really influenced by what that first post-acute care setting of care is. It's also
is
true
swing
that
bed under inpatient rehab?
Swing bed would actually be, it's not shown here because swing bed is not included as a separate post-acute care setting from CMS's standpoint for this purpose, but swing bed would be another example of another component of post-acute care. So that's a great question. It's not actually shown in these examples, but it would also be a relevant component that that some entities would include if they were looking at their episode of care and looking at their care continuum. So that's a great question. It just happens that that swing bed is not included here, but it certainly would be applicable for some entities for sure. I don't know, Carla, do you want to add anything to that?
No, I think that you answered that question. It's not included in this particular, in what CMS has, what we have as far as our literature and the data that they're collecting.
But yes, that would be, so if an entity was trying to form a partnership with other providers and swing bed was an important component of that system, that healthcare system's care delivery, then they most definitely would want to look at the swing bed cost as a component of their episode of care. So great question. Anything else before I move on to the last example of the newest CMS bundle payment arrangement? Anything else that would be helpful to talk about a little more? Okay, so hearing no other questions at this point, the last section of our presentation is to talk a bit about the most recent CMS initiative. This one is called the Comprehensive Care for Joint Replacement Model, affectionately dubbed the CJR Model, and it is brand new. This actually was, the rules related to this initiative were finalized in November of 2015, and this program just went live in April of this year. So it's very new. It is a 5-year bundled payment initiative, and it specifically focuses only on lower extremity joint replacement episodes of care, and more specifically total knee and total hip replacements. The key that's really a game changer, frankly, for many, many hospitals across the country is that unlike that first arrangement that I talked about, the bundled payment, that first bundled payment initiative that I talked about being voluntary, this one is mandatory. So bundled payments for care improvement initiative was CMS's first foray into this reimbursement arrangement world. That one started in 2013. They then have really upped the ante, if you will. And as I say, in November of 2015, they finalized the rules and announced all of the regulatory requirements related to this initiative, and it is mandatory. So that is a really big change. It is the first time that hospital systems across the country are now required to participate in a bundled payment arrangement if they are delivering these services to Medicare beneficiaries. Similar goals to what we've already talked about. CMS has been very consistent in saying that their goals for these alternative payment methodologies are, again, to improve coordination of care, to improve quality of care across that whole continuum. So from initial hospitalization through recovery, in this case where we're dealing with orthopedic surgical interventions. Their goals are to reduce the total cost of care, and they were really intentional in selecting total hip and total knee because those particular surgical procedures represent significant cost. As you can see what the average cost is, and there's quite a lot of variation across the country, and there are a lot of regional variations, both in cost and in care patterns and in clinical outcomes, anywhere from $16,500 to $33,000 as the average cost for that episode of care to perform hip or knee replacement surgery. And in fact, CMS's data indicate that those two, the hip and knee replacements, are the most common surgical procedures billed to Medicare. So it makes total sense that they would start this mandatory bundled payment arrangement. They are starting with those two expensive and very common surgical procedures. In this model, this involves acute care hospitals that are paid under the inpatient prospective payment system. So at this point, critical access hospitals are excluded from participation in this this hip and knee joint replacement model. That is not to say that may change in the future, but at least here initially they have been specific to say it will be the inpatient prospective payment system hospitals. Acute care hospitals, they identified 67 metropolitan statistical areas across the country, and as of November of 2015, when they finalized all this, that represents that those 67 MSAs encompass about 800 hospitals across the country who are now required to participate in this bundled payment arrangement. And again, from CMS's perspective, this now really gives opportunity, and it really requires these hospitals to now more carefully, more closely partner with the surgeons, other physicians, and post-acute care providers involved in delivering care to their surgical patients. And it is very specific, as I say, to these two MSDRGs, specifically and only includes in this model MSDRGs 469 and 470. And as I mentioned already, really with some minor exceptions, are really focusing on the total hip and total knee replacements. In this model, CMS has determined what the length, what that period of time is, and it's the hospitalization and a 90-day post-discharge period. As you may remember, when we were looking at the other voluntary option, there were choices. It could have been a 30, a 60, or a 90-day post-hospital discharge period. In this model, CMS has specified that it includes a 90-day post-discharge period, which is a sizable length of time, and obviously considerable care may be necessary during that period of time, that post-acute period that's been included, which then would all those costs directly related to that surgical intervention would be gathered up and would be included in determining the total cost for that episode of care. As you can see, it includes almost all Medicare Part A and Part B services. This arrangement is what is called a two-sided risk model. As you may remember a few minutes ago, I talked about unlike the traditional fee-for-service reimbursement, unlike some of the pay-for-performance arrangements that are out in the marketplace, in this bundled payment arrangement, hospitals are bearing the financial risk. And the first performance period of this 5-year period just started in April 1st. One of the other requirements that CMS included in this model, which is not included in the other, is that for the first time they've tied directly a quality metric to the model, in that beneficiaries must be discharged to skilled nursing facilities that are rated a 3-star or above on that CMS 5-star rating system for nursing homes. Over that time period, as you see, they have to maintain a 3-star or above rating for at least 7 out of the previous 12 months in order for that length of stay at that skilled facility to be included in the bundle. So as you can see, CMS is becoming increasingly directive in really trying to increase focus on both quality and coordination of care. They've defined a 90-day period here, so it really is scooping up quite a lot of time in that immediate post-operative period. And they have been explicit about assigning a composite quality score. They have identified 2 specific measures, which you see here on this next slide, which are complication rate, and then a member or patient satisfaction, the HCAP survey score results, and they've selected 11 measures out of that survey. So hospitals have to achieve a minimum score on these composite quality measures in order to be eligible at all for a reconciliation payment. What I mean by that is there is opportunity in this model for the hospital and the participants, if they have a lower total cost than what CMS has predicted for these surgical procedures for that 90-day period, then in this model, the hospital and their partners have opportunity to share in those cost savings. But they are only eligible to do so if they have achieved the minimum threshold on the composite quality scores. So CMS has been, as I say, very intentional at integrating quality and quality metrics as a part of this model, and that directly impact then the financial results for the participating hospitals and their related partners. Let me stop with that and let me see if there are questions about this aspect of it. The expectation is that this is the first of what are likely to be many other bundled payment arrangements involving other surgical procedures. Coronary artery bypass grafts have been identified as a potential target for a future bundled payment arrangement. There are also medical bundles that may be considered. Those can be more difficult because it's a little bit harder. It can be harder to really clearly identify a starting point. A surgical intervention is pretty straightforward. You have a clear starting point of the admission and the delivery of that, the performance of that surgical intervention, which is in addition to the high volume and the cost implications of these surgical procedures. It's thought that those are other reasons why CMS has started with these orthopedic procedures. But the expectation is that if results are good, if there are demonstrated savings and demonstrated improvements in coordination of care, quality of care, that it is very likely that CMS will expand this model and look at other models, look at other bundled payment arrangements for other clinical conditions, other surgical interventions. So with that, I will pause and see if there are other questions.
You can press *2 to unmute your line, or you can type a question into the chat box.
And actually, we're happy to take, if there are any questions that you all have thought of as a follow-up to last week's presentation, particularly around, readmissions. We touched on last week Interact, which is that very, it's pretty widely utilized. It's that quality program targeting skilled facilities. But again, it's particularly focusing, Interact is particularly focusing on improving transitions of care and increasing communication and collaboration, in particular between area hospitals and the skilled facility. The Interact program has been, as I say, widely adopted as a best practice on the part of the skilled facility to improve the information, the clinical change of condition information that the skilled facility is collecting and then communicating, so that if transfers are indicated and medically necessary, that they are improving the coordination across those settings of care. And then also intense focus on really developing the skills at the nursing home, at the skilled facility, to identify earlier on changes of condition of the resident and earlier interventions with specific goals of reducing transfers to either the emergency room or for hospitalization. And one of the recommendations that we give to both skilled facilities with whom we're working as well as hospitals is to really, if from a hospital perspective, to really first identify who are your main skilled facilities in your market, in your service, your delivery service area, and then what are your experiences with those skilled facilities? Are there high numbers of residents? You're discharging somebody that's going to a local SNF. Are you experiencing high numbers of readmits or high numbers of folks transferring back to the emergency room? We really recommend that the hospital then take that opportunity to really identify those patterns, and then if it's an important skilled facility in your system, in your market, to then begin to have these conversations and to really encourage that facility, if they're not using tools such as the Interact tools, to really begin to adopt those tools that will really support improved transitions of care and support earlier interventions to reduce avoidable transfers.
Louise,
I don't know.
Is this payment method projected to lead to a decrease in the number of post-acute providers in the higher cost settings?
That's a great question, and I will tell you that the short answer is yes. There are ranges of estimates, but there is definitely consistent thinking that over time these sorts of arrangements will likely result in a winnowing out, if you will, or a reduction in the total number of post-acute care providers in a given market, in particular skilled facilities, especially what may be the smaller facilities that perhaps struggle with staffing, may have clinical quality challenges because of staffing challenges. The thinking is that there will indeed over time be some winnowing out of some of those skilled facilities because they won't be able to really deliver the results. There'll be quality issues, and definitely there are facilities that have much higher hospitalization, readmit, and ER utilization rates than others, and that payers, whether it's a health plan, a hospital system, will begin to really carefully look at that. And in fact, recommendations we give to our clients, if they are really trying to look at the post-acute care component in their delivery system, is to be to begin to really look at those patterns and to identify who are the top performing post-acute care providers in their service area, and to begin to develop preferred provider arrangements that can be a simple, agreement to collaborate and to share data and to share evidence-based protocols, all the way up to formal relationships. You really see across the country kind of an emerging range of options. But absolutely, in this sort of a reimbursement environment, the hospital system or the health plan absolutely has to be really looking at quality and cost and utilization history of their post-acute care partners, business partners. Great question. And the two, you absolutely hit the nail on the head. The expectations are inpatient rehab facility utilization is likely to shrink in the future. Certainly if somebody is medically appropriate to discharge to a lower level and therefore a less expensive setting of care, that will be the preferred approach. And then likewise that there is likely to be a reduced utilization of skilled facilities and an increased focus on outpatient therapy services, as an example, outpatient rehab, home health services if somebody needs that level of supportive care, and discharged to home with some combination of home health or outpatient services as an alternative to the more expensive skilled facility arrangement. And I would say in some markets that's already happening.
Louise, for hospitals that are doing this well, what are they doing to make the bundled payment successful?
Yeah, that's a great question, and I think it goes back to some of those factors that we talked about earlier on. It's really, really important that the hospital and their partners, in this case in the CJR, it would be the physicians and then any post-acute care providers that are likely to be utilized in that 90-day period, that there is an upfront conversation around, I'm going to go back to this slide here that outlines some of the success factors. So care redesign is just hugely important. And that's why I was talking a little bit more about, the whole idea of looking at what are the post-acute care providers, what has been their trend around quality, around length of stay, around transfers back to the ER, back to the hospital, because all of that is going to impact the total cost that hospital then is going to be responsible for in terms of that episode of care and in terms of that bundled arrangement. So really taking a close look at who are the providers, the post-acute care providers in that hospital's market. Where are your patients going? If it's a more rural area, there may only be a couple of post-acute care providers available, and so then that really then, I guess, increases the need to begin to really have those collaborative conversations, and ideally to then have joint decision making around, yes, we are in agreement that if somebody is a total hip and we discharge from our hospital to XYZ skilled facility, that evidence-based clinical protocol is followed on through in the post-acute care setting, that that the hospital has a pretty good comfort level with the rehab services that are offered in that facility, as an example, for certainly for the total hips, the total knees. What are the complication rates? First place to look would be nursing home compare. What does that data really show in terms of that skilled facilities survey results? How do their staffing patterns stack up to national benchmarks? What about whatever the data might show around their complication rates, infections, decubitus ulcers, adverse events such as falls? All of those would be things that would be important for the hospital to really be looking at and asking about, and then potentially really partnering with those key post-acute care providers to help them to raise the bar, getting an agreement around evidence-based clinical practice guidelines. The Interact toolkit includes some really nice tools that if the skilled facility in the hospital's service areas are not using, to really encourage, hey, if you aren't aware of this, let me introduce you to Interact. There's a transfer checklist as an example to try to help to make sure that if somebody does have to be transferred, that the basic clinical information is sent with the individual, so that when they show up in your emergency room or they're being admitted, you have some baseline information about what medications they're on, what's been the medical history, and so forth. So there's a nice, and the idea is that then the nursing home will standardize and consistently use those tools. What kind of physician coverage is in place in that skilled facility? Is there ready coverage by a nurse practitioner, a physician's assistant, or a physician, so that if a member has a change of condition, there can be initial evaluation an intervention without having to send somebody to the emergency room. Those are the kinds of things that some of the hospital systems across the country are putting in place as a way to really maximize the likelihood of success in a bundled payment arrangement environment.
Great. Thank you so much, Louise. We have about 5 minutes left.
Okay. Any other questions? Great questions. You all are asking exactly the right questions. These are excellent questions. I think the other aspect that I didn't say too much about, and I mentioned it earlier on, but from the standpoint of success, the other thing is, again, really doing for that hospital and their partners to do as thorough a job as they can at identifying what are all of the components of care in that 90-day period, what are all the costs that you need to expect in figuring out whether or not it's a viable financial arrangement to, you know what CMS is going to pay, and the goal would be to have total costs for the episode come in under that CMS target so that then there's opportunity for shared savings. So identifying all the components and really accurately figuring out the cost is very key up front to be successful in a bundled payment environment. Anything else? All right. Well, thank you so much. We really appreciate your participation today and your attendance and the great questions.
Carla and Louise, thank you so much for a great webinar series. The recording of this webinar, along with the webinar from last week, part 1, will be on our Health Webinar Playbacks page later today. At this time, I ask that you complete the short online assessment for this webinar. Use the links on the screen to register for any of our upcoming webinars. We just added 2 new webinars, or download the educational guides or the Rural Hospital Toolkit for transitioning to value-based systems. If you have any questions or comments, please contact me at the email link on the screen, and we hope to have you on future calls. Carla, were you going to say something? I didn't mean to interrupt you.
Oh, no. I was going to thank you and really, just to kind of back up what Louise said about Interact, I really suggest that everyone go to the Interact site because there are multiple tools that are free and ready for use on that site. They have a wealth of resources.
All right. Great. Thanks so much, everyone. Have a great afternoon.